Hey, everybody, welcome back to another episode of Dentistry Unmasked. My name is David Rice, and I'm here with.
Hey everybody, Pam Maragliano-Muniz. I could not wait for this episode because I feel like if I wasn't in a room by myself, this is the in the room by yourself equivalent to like sitting down, having coffee with one of my favorite, two actually, of my favorite people. So this is fantastic. Dr. Courtney Lavigne, welcome. I'm so happy to chat with you.
Thank you. I'm excited to be here. I've been looking forward to this.
So if you don't know Courtney, which you probably already do, but if you don't, here's a very Cliff's Notes version of Courtney's background. So I met Courtney back when she was a Massachusetts dentist, and everybody kind of was like, "Do you know Courtney? You have to know Courtney. You should know Courtney. She's a really great dentist." Oh, Courtney, great dentist. And so finally I got to meet her, and she's like, ball of energy, totally passionate about what she does, went through like the whole spear curriculum and was one of those people that took the education that she obtained and brought it into her practice and made an incredibly successful practice, startup practice, and is also certified in AACD. And you're like, all right, that's cool. That's great. So she's a great dentist. Those people were right. But no, 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 she wasn't done. She decided, while I am an incredibly talented restorative dentist, that isn't my 100% passion. And so now she's an orthodontist. And so now you get to see things from both sides. So I know that is like not even close to touching the amazingness of your CV, but is that like a good generalization of the story?
Yeah, that's usually the part of the story where everyone's like, "What did you do? Why?"
So why? Yeah, let's start with that.
Yeah, I say that I did 30 years of dentistry in 10 years because I was one of those people that graduated dental school, realized how much I didn't know, hated not knowing the answers, and just took so much CE and wanted to do everything the best I could, implement everything. And started my practice that I started from scratch was really honed in on doing aesthetics, especially going through AACD accreditation and then full mouth rehabs, more complex cases. And those are really challenging cases to do. It's a challenge to manage the patient and their emotions. The finances are very large, so there's a lot of stake for the patient. Your lab bills are high. There's a lot of stress behind it. And I had kind of checked every box in my practice. I couldn't make it better in my mind. I had the perfect team. I didn't want for any patients. It was thriving. My build out was great. I loved the location I was in, and I still wasn't totally happy. And in the background of that, two separate things were going on. One was my own health history, which it's a very long, we could spend a half an hour talking about my health history, but at the end of the day, I was diagnosed with upper airway resistance syndrome and had a lot of sleep and breathing issues going on that circled back to dentistry, which I had never thought that the field I was in would affect me. I wasn't a person that had a lot of dental stuff going on. So that was one. And then secondly, I would come back from these CE events and I would see the orthodontics that Vince Kokich did to work with Greg Kinzer to make these beautiful cases. And I would present my nice keynote with, please intrude this, please move this. I need this much space for the implant. And I would send my keynote off to the local orthodontist I worked with. And they were like, we can't do that. That's not possible. We have to do it this way. And I got to a point where I wanted to know, can it not be done, or can it not be done in your hands? And that question just kept getting bigger and bigger and bigger. And so the combination of being frustrated with learning about the airway component of orthodontics and not seeing that practiced in my local community of orthodontists, in combination with my restorative plans, I felt like my limiting factor to doing them correctly, how I was trained, was the orthodontics. I finally threw up my hands and I said, I'm going to answer this question for myself. And I sold my practice January of 2020, which ended up being really phenomenal timing for me. I went back to residency, became a board certified orthodontist, and now I'm practicing orthodontics, but I truly feel like I approach it so differently because I think like a restorative dentist, but I know the mechanics of an orthodontist. So I don't approach it in the same way a traditional orthodontist would, I don't think. And it's been really fun to be able to put the two of them together.
So, how much do your referring GPs love you because you have that perspective of the end in mind, not just but from the ortho standpoint, but from that restorative dentist standpoint.
It's funny because there's a varied population of referrals that I get. And so Rebecca Bacow is an amazing orthodontist out of Seattle. And she told me the hardest thing you're going to have to juggle is you're going to know the restorative dentistry and want to do it one way, but you're not the restorative dentist anymore. And so I find like I have a couple of referral sources that are COIS trained and SPEAR trained, and they think very comprehensively, and they love sending their patients to me, and they send their patients a long distance to see me because I'll look at it and say, based on the wear on the teeth, if I ideally position the teeth, you're now going to need these restorations. And I do facially generated treatment planning to give them the full picture. And then they're getting their patient back in their office ready to do 8 units of dentistry that they didn't have to talk to the patient about because I did it for them. On the flip side, I have other referral sources that don't feel as confident in their comprehensive skills. And they're like, can you do the bonding on the laterals? I think you're more comfortable on that than I am. So I really have to work with who's referring to me to know how much do you want me to intervene? How much do you not want me to intervene, and meet them kind of where they're at. So kind of all across the board I found, which has been a learning curve for me as well.
So why not go? I mean, you obviously took CE to another level. Why not just go to courses at Align or whatever and be a general dentist that is really good at orthodontics?
I'm actually putting together an entire curriculum on orthodontics for restorative dentists because I think 2 things have happened. One, I think that orthodontists keep all of how they treatment plan and are trained to think in a vault because they want to protect that they're the best to do it. And on one side, I can see why, but on the other, I think that it's one of the most underdiagnosed areas because as a specialist, and you're a specialist, you know this, like a lot of your patients are not just direct to consumer, like, oh, I need a new dentist, let me look you up. They're coming to me because somebody sent them to me. And so I think they don't want general dentists doing all of the orthodontics and it doesn't show up in their office, so they just don't teach it. But I really feel like the more I've worked with my colleagues and helped them on cases comprehensively, I've realized the thinking and treatment planning skill set between a well-trained restorative dentist and an orthodontist are very different. And if you could meld the two together, I really think it's just going to lead to more care being provided and a higher level of care being provided, because a lot of restorative dentists don't know what they don't know in orthodontics, and they don't see their patients in their hygiene checks and realize if we sent you to the orthodontist and got your case set up now, X, Y, and Z would be improved. And I really think bringing that knowledge to the restorative dentist can elevate both what they're already doing with clear aligners in their own offices, but also the referrals they know how to send out and how to communicate to the orthodontist what they want. Because that was always my struggle. I would think I knew what I wanted, send it to the orthodontist and not get back what I wanted, or they would say, we can't do that. So I'm really trying to put together, I'm trying to meld the 2 sides of my brain and make it presentable in a way that a restorative dentist could say, okay, I understand orthodontics a lot more confidently now. I know what I should do in my own office. I know what I should refer out, and I know how to refer out more effectively. So that's kind of where my efforts at home have been in the past couple months.
I love that. Okay, so I have to ask you about one of your origin burning questions. Did you discover that it wasn't going to work in that person's hands and it couldn't be done because of them, or just that there were many things you wanted to accomplish that were really difficult to do?
So I've learned a lot. I really thought I knew everything I needed to know going to residency, except the engineering of tooth movement. I needed to know the physics behind it. And I realized, oh, how I'm trained to treatment plan is not the same as an orthodontist. And it was humbling. And I had to learn a lot of new things in residency I wasn't anticipating, which made it a lot more fun. But I learned that I think we think of orthodontists as this like uniform, like you're an orthodontist, you move teeth, and that they're all the same. But it's very similar to the way that you might go to one general dentist and they do posterior teeth and they know how to do fillings and crowns. And you go to another general dentist and they do full mouth rehabs and they do veneers and they're into the cosmetics. Those are 2 very different practices, and you shouldn't have the same expectations of outcome from those 2 practices. Similarly, I found out that it was the orthodontists the ones that I was working with couldn't do it, but it could be done. But you need adjuncts. So I use a lot of TADs in my practice, and that can allow me to do things that if I were just using aligners or I were just using braces, I couldn't accomplish what I was previously asking. But there are also some tooth movements that I would ask for things that I didn't really understand how to mold together, resolving a certain amount of crowding with the amount of bone that was available. And now I look at a case and I recognize, okay, there's a math discrepancy between the foundation we have for the house and the size house I'm trying to put on it. And I now know how to reconcile those things in a way that there were things I was asking for that weren't possible. But the large majority, I would say, it came down to working with providers that didn't want to do complex adult orthodontics, and I was asking them to. And so in orthodontics, I found that there are orthodontists that never do phase one. If you want your 7-year-old to be expanded, that's not the practice to send them to, because they're not intervening early. They're seeing you once you have your full adult dentition. There are other practices that don't see adult patients. My practice, I was just looking at the numbers. I see 56% are adults and then the rest are kids. So I'm pretty split in between. But you really have to know who the orthodontist you're working with is and what they want to be doing. And I wouldn't want somebody to have pushed me to do root canals in my practice. I know the outcome wouldn't be good. I wouldn't enjoy it. I wouldn't want to be the person receiving a root canal from me. And so I feel like asking an orthodontist to do treatment that they are not comfortable with, don't want to do, don't enjoy doing is similar to that. But I hadn't recognized that until I went through training.
How do you find a comprehensive orthodontist? Is it about having those conversations, going out to dinner and having a deeper conversation philosophically about your approach to care? Or are there organizations or websites or something where you can at least have a good place to start?
I think largely it's having a conversation. And what I've recognized, I approached interdisciplinary care as a restorative dentist in the wrong way. I would go to one of my orthodontist office or meet them for dinner, and my approach would be, here's what I want from you. Here's what I recently learned and what I'm asking of you. And then it kind of puts somebody on the defensive. Like they feel like, okay, well, you're a top referrer of mine, but that's not how I operate. And then it's an awkward situation to put them in. I now recognize I was really well intended in those situations. But if I were to go back in time and do that all again, the way I would approach it today would be to take them out to lunch and say, what kind of cases make you tick? What are your favorite cases in your practice? And what is the large majority, like what's your treatment planning philosophy? What age groups are you treating? And then if they say, I'm treating, 12 to 14-year-olds is the lion's share of my practice. Okay, do you see anybody younger than that? Are you doing a lot of treatment on 7 and 8-year-olds? If they're saying no, don't then try to push them on your agenda to do early intervention orthodontics. Move on to the next orthodontist. And now okay, this is the person I refer to for my phase 2 therapy, full adult dentition. And that's where they, and kind of feel out who you should refer to for what. I used to tell them what I wanted as opposed to asking what they could provide. And I think there's a big difference in those conversations. And I wish I could go back in time and reformat how I had those conversations.
Have you chatted with them after?
I haven't. Life has been really busy since I got out of residency, and I haven't been in Massachusetts as often. And I probably should just reach out and, you might be the prompt for me to actually just shoot an email and say, hey, I didn't know what I didn't know. Here's where I'm at today. Thanks for what you provided in the past, and kind of touch base with them again. It might be a good opportunity. And I didn't answer the second part of your question, but in terms of organizations, I found that because the orthodontic community is a much smaller group than restorative dentists, there aren't as many opportunities to go to different, like you can be Coist trained, you can be spear trained, you can go to Pankey, Dawson. There are all these different places that you can go for training. The AAO is the main meeting of the year. Whereas I wouldn't say most general dentists would look at the ADA meeting as like the go-to, or like the AGD as the only meeting of the year. So it's not as simple to find out what philosophies your orthodontist that you're working with have. If they're going to higher level education that include restorative dentistry, like if an orthodontist is Coist trained as an example, like that lets you know that they know more of the adult comprehensive. But other than that, I think it's more personal conversations and finding out who they are and what they like to do. And sometimes you can gather that from what they're trying to achieve on their website. But a lot of times I think the most effective way would be to just have a conversation.
I spent a day with Regina Blevins in like St. Paul. I'm not sure if you know her or not, but
I do. Yeah.
so the smile on your face tells me the story that was my experience was I cannot believe what she is accomplishing in orthodontics, and it was shocking to me. So what's surprised you in like the best way as you've gone through this training of what's possible? You know, you mentioned tags and things and adjuncts you're using, but like what do you look at and think like, I can't, this is so exciting for me, I can't wait to do more?
Um, I have really been, and this is where I think there's so much education to bring to restorative dentists, but I hadn't given enough clout to how much the sagittal dimension and what you can learn from looking at the sagittal dimension affects your aesthetic dentistry. Like how proclined or retroclined your upper incisors are going to completely determine the line angles and the aesthetics of your end result. And I mean, I'm accredited through the AACD. I'm completely spear trained. I was visiting faculty there. And I'm trained to look at facially generated treatment planning, but from head on. And so I know tooth size proportions, and I know, where I want them in the vertical position, how much incisal edge I want to be seen at rest versus smiling. And I know all the reasons for a gummy smile and how to address that vertical proportion. But I didn't know until I was trained orthodontically to look at skeletally. You can have a dental class 1 occlusion, and they can be severely skeletally class 2. And their chin prominence and their incisor, you're going to have retroclined upper incisors and proclined lower incisors in a class 2 that's compensated to a dental class 1. And once you start to really look from that side view, it unlocked a lot of cases where I would have restorative cases where the patient still wasn't like, they didn't have that wow factor after I restored them. And I'm like, what's missing? I did everything right. And I think looking at a patient's 45-degree angle shows you what they can see of their profile. I was so trained to look head on and completely to the side, and a patient can't see themselves from their profile. And what really tends to bother a patient is what they see at one side or the other. It's why everybody has like a good side in photographs. And I think that's been the most exciting thing is before my orthodontic training, I felt like I would take CE and I never knew something that the lecturer didn't know. I always felt like there was somebody that knew more than me, that was smarter than me, that I would never get to that level. And I've had a lot of aha moments that I feel like I've sewn together my restorative training with this new orthodontic training that I have, and looking from that 45-degree angle and really knowing the skeletal position and the tooth position from the side has made a huge difference in how I look at dentistry as a whole. And it might not affect my referral sources, or the patients might not realize how much I'm putting into it, but it's personally very fulfilling to feel like I've unlocked something that had always bothered me, but I wasn't sure what was bothering me. So I'd say that's the most exciting. And then the other thing I love doing is TAD intrusion to treat gummy smiles non-surgically, because it's so hard to get patients to accept surgical treatment when it's invasive or depending on their age. And I can just see really crazy results in a short amount of time doing that. And I hadn't been working with anybody doing it in the past, so it was new to me. And that's been really fulfilling on more of like a day-to-day treatment planning from that perspective. So I'd say those are probably the most exciting areas.
I love that. I always say, don't treat an orthodontic problem restoratively. Don't treat an orthodontic problem surgically. Like if you know what the problem is, treat it with the special, even if it takes more time. And I always tell my patients it might take more time up front, but long term, you are creating a better situation for health and for minimal intervention. So that's just my little soapbox there. Now, there's still a lot of general dentists that are listening to our podcast, and I have two cases that are just like jumping out at me that I feel like I have to talk about. One is just technique for IPR. I have a patient that came in who we had to open all of her embrasures because she was left with legitimate ledges, and then have to go back in and do like a second phase to kind of close everything back up and put everything back where it needed to be. So this poor woman who had virgin teeth now have little like class 3, class 4 bonding on every single like from basically first buy to first buy because of these ledges that were created. And then I have another patient who has lateral incisors that they look like a little woodchuck. They're like, I don't know, maybe 5 millimeters wide, because they were IPR'd to death, and then everything was just so closed. And obviously that's not great from an airway perspective, but aesthetically it's terrible. So are you sharing your amazing tips to safely and effectively provide IPR on teeth? Because I think there's a lot of help that's needed out there.
Yeah, so I think that the answer to that is twofold. One, the diagnosis of IPR being needed and prescribed is part of it. And two, it's the technique. Because on the front end, this comes back to not knowing how to communicate with your orthodontist. So as an example, if somebody to start has a tooth size discrepancy and they've got small upper and lateral incisors and normal lower teeth, there's a math equation where you can't get appropriate anterior overjet and overbite unless you make the upper arch bigger or the lower arch smaller. And if there's no communication between the restorative dentist and the orthodontist, then the orthodontist makes that decision. And depending what the orthodontist philosophy is, you're going to have a lot of orthodontists that will say, okay, there's a tooth size discrepancy. And to be honest, there's a lot of bad composites done out there. So they might decide, I'm not going to put this patient through additive treatment and need to maintain that composite that they're going to have done. So they'll make the decision, I'm going to IPR the lower teeth and retract them so that I can get a better overjet situation with this math equation that doesn't add up. The problem with that is you end up with ugly lateral incisors, and it makes the front two centrals look more prominent, and it deepens the bite because you've taken a relationship and retracted those lowers instead of being able to procline the uppers. And so you end up with a deeper bite that, depending on the occlusal scheme, can wear the teeth prematurely. So that may have been a situation with better communication, that if the restorative dentist says, hey, there's a tooth size discrepancy, only do a minimal amount of IPR if needed, but my way that I'd like to handle this is by adding 1 millimeter to each of the laterals. Please put 2/3 of it on the mesial and 1/3 on the distal, and I will restore at the end of treatment. Now that orthodontist is not making the decision, the restorative dentist is making the decision, but I never knew that was even something that was a decision that had to be made prior to my treatment. So I wasn't sending cases off to I just assumed the orthodontist knew what to do, and they do, but they may not be making the same decision as you, and they may not be having the same conversation that you are. Because if you say to a parent, we can do this one of two ways. One way, you're going to have to add an expense by having to see your general dentist, and then they're going to have to maintain it every 5 to 10 years or something like that. Or I can just reduce a little on the bottom and fix it. The way that you present that, that parent's going to say, well, I don't want to do that first option. It sounds terrible. If the restorative dentist says we either have to slenderize your bottom teeth and remove healthy tooth enamel, or we can improve the aesthetics by widening these teeth that are the wrong size to begin with, what would you like? Well, that parent's going to choose to add composite. So how you say things and how you talk to the patient, the parent, that's all going to come back to what the ultimate treatment decision is. And I don't think the orthodontist knows to ask the restorative dentist what they want. And I don't think the restorative dentist is often asking for that from the orthodontist. And so there ends up being just this misdiagnosis of the IPR might not have been the right solution from the beginning. The second half of that is that as a restorative dentist, I am an enamel worshiper, but I also recognize that if there isn't enough bone and a patient doesn't want to go through surgically facilitated orthodontics, or it's really hard to justify that procedure in a very healthy dentition, then you need to reduce tooth size to get the teeth lined up. But if you look at David Sarver has like a beautiful technique for doing IPR, and there is a way to take a tooth that has a certain contour and give that contour back to the patient if you adjust the enamel appropriately. But if you just take a disc between teeth and you go up and down, you're going to end up with really sharp edges. You're going to end up with really broad contacts, and you can run into trouble. And I think you really need to evaluate, well, what do the teeth look like to start before I decide to IPR them? Because if you're getting your first aligner plan back and it just says do 0.4 millimeters of IPR from lower canine to lower canine, and you don't stop to say, are these really triangular teeth that will still have a nice emergence once I reduce? Or are they already like, they might have already had IPR in another office and you didn't even stop to question it. And that's where you can run into kind of egregious IPR that the teeth don't look like teeth anymore. They start to look like blocks. And that's where you can really do some damage to the function and the aesthetics for the patient.
So you mentioned a couple names in there and great points in there without without GPs going to be weekend warriors, it's never works and never a good thing. What orthodontic courses would you maybe recommend to them just to get the average GP thinking like an orthodontist, so we've got a better awareness of, hey, if I see this, I should be thinking this, and then I can have a better conversation with my orthodontist because I'm more knowledgeable.
Yeah. That was something I struggled with, and I couldn't find courses that when I was taking any, because I was doing aligners in my office, in my head, I was doing the simple cases that were just preventing the patient from having as much tooth reduction when I then went to restore them. But whenever I took courses, I was a general dentist being taught orthodontics by a general dentist. And there aren't a lot of orthodontists that are willing to teach orthodontics to general dentists. And that's where that kind of vault mentality comes in of like, let's keep this lock and key. But if you think about it, endo, how many general dentists do endo and they send their more complicated cases out to the endodontist? And a lot of general dentists place implants and they send their more complicated stuff to the surgeons. I think that we would all be better off if the knowledge were more readily available. And that's where I've had enough people asking me, hey, could you hop on a call? Hey, that I'm finally just putting the content all together. My husband's a video producer. So I was like, this is easy to do from home. Let's just do it. I'm trying to put the content together to teach orthodontics to general dentists in a way that is digestible to a general dentist. Cause I feel like I still think that way. But I think it really is hard. I see a lot of my colleagues will send me ClinChecks from Invisalign and they'll say, hey, can you look at this? And I'm like, there aren't x-rays or photographs that I can diagnose. Like just looking at the models, is this canted? What does it look like in the face? Can I be proclining these incisors? I don't know what they look like in bone. And Adamo is a good friend of mine. And I remember when I said to him, he sent me a case and I was like, do you have a CBCT or a Ceph view? And he's like, you are such an orthodontist. It was almost like he was insulting me, like, oh, you've gone off the deep end. But it's because I now know what to gain from those images that I didn't know before. So I want to bring that to be common knowledge so that if you are doing clear aligners in your office, you know what the standard of care that you should be working within is. Because right now, I don't think anybody knows. I think if you have an FMX and you checked the health of tooth by tooth, you're like, okay, I can do this case. I've checked in, but it's not the full answer. I have a couple examples of cases where the lower incisors weren't IPR'd and they were proclined so much to resolve too much crowding that the lower incisors ended up being extracted because they were completely moved out of bone. So I wish there were more courses. There are a lot of good courses out there on mechanics, teaching you how to put brackets on, teaching you where the attachments go. But if your initial diagnosis and knowing your limitations is not there, the mechanics don't matter. And so that's where I think everybody wants to know, where should my attachments be? Am I using the wrong side? Am I getting a posterior open bite because I did the wrong, Invisalign plan? And no, you didn't diagnose it appropriately before you started figuring out where your attachment should be.
So how are we going to get this education? Do you have a name for it already? Or should we just follow you on Instagram and then you're going to surprise us with a drop? Like, how's this going to happen?
It's funny because I'm working on it on the side of, everything we have to do as practice owners and opening a second location right now. I'm really stuck on a name. My husband and I have been trying to go through it, thinking of a name. So we'll get there, but I don't yet. I've the intro's done. I've got the 6 modules outlined. It's going to be a 6 module with bonus content. I already know exactly what I want to get across. It's taking an unbelievable amount of time to get through the modules because I'm doing it with references. I feel like it's really important for me not just to say, here's what I've learned, but to say, and this is supported by research, or go to this textbook if you want to learn more about it. So I'm really trying to do it in the right way. I'm planning to be able to roll it out in January. I've definitely taken a hiatus off of Instagram. I used to be very active on it, and I kind of recently just got on and had my first post again in a very long time, but I'm going to try to be more intentional on it. So I would say Instagram is probably the best place to keep up to date right now. I'll probably do a founder circle of a small group that wants to get started with it for a discounted price so that they can give me feedback. And if there's anything I need to change, improve, or make better before I release it to the masses, then they would be my key people. So if I can persuade you to want to be on board and watch it ahead of time, I'll reach out to you.
I'm always here for you. So
I'm also
please.
raising my hand for this.
Okay.
Yeah,
Awesome.
absolutely.
I've got
I
two
think
signed up
Totally.
then. Perfect.
yeah,
Yeah.
no, it's so, so needed. So
Yeah.
would you share your Instagram handle?
Yes. It's Courtney Lavigne, DMD, and it's the French spelling of Lavigne. So it's Lavigne.
Amazing. So you gave us so many pearls and so many things to think about from a different perspective today. And I just always love any time I have with you. So clearly, we need to have you back. Certainly, we would love to maybe chat with you in the beginning of the year as you roll this out, because I can imagine this is going to be wildly successful.
Mhm.
So, congratulations and thank you for this contribution. I think this is a big deal for general dentists.
It's so well needed.
Yeah, I felt like it was needed for me. So it's kind of my way of giving back, because I feel like it is an area that has been underserved for a long time. So I'm trying to do my very best to make it effective, and hope I can get some feedback from those that are smarter than me in the restorative world to make it as good as it can be.
I love that so
That's
much.
incredible.
I am literally your perfect example. Post ortho growing up, a GP thought I was going to be a slam dunk, did clear aligners, like, it turned out okay. I ended up going to my orthodontist who, immediately transformed the result. And I'm like, oh, that was not difficult, but that diagnostic process was so key. And it was just,
Yeah.
not a bad GP, just maybe beyond the scope of the education that was out there for him at the time. So I'm personally also very excited for this. Thanks for being here. Friends watching, listening, thank you for being here. And Pam, I don't know how 30 minutes sprints by.
It really does. But the good news is we'll be with you next
We'll come
week.
back.
So come on back. So, everybody, for Dentistry Unmasked, thanks for joining us. And we can't wait to see you all next week. Bye.
Bye. Thank you, everyone, for watching or listening to the show this week. And thanks to our guests and sponsors on this episode.
Please check out our social media at Dr. Pamela_Maragliano and at Dental Economics Official.
Or you can check me out at Ignite DDS or at Dr. David Rice.
And go to dentaleconomics.com to receive dental economics. You can choose to receive DE in print or digitally, and you can also get the details of our Principles of Practice Management conference on our website.
If you have topics or guests or anything you'd like to talk about on the show, send us an email to dentistryunmaskedpodcast@gmail.com, and we will do our very best to make it happen. Thanks again, and we'll see you next week.